Hello, everyone, and thank you for joining us for this education session addressing health disparities through governance, diversity, and inclusion strategies to achieve health equity. Along with the download of this audio file, you also received a link to the materials for this session. If you encounter any difficulties, please contact us at 512-465-1060. Be sure and check out our other education offerings at www.tht.org. It is now my pleasure to introduce our speakers. Marcos Pesquera is the System Vice President for Community Benefit, Health Equity, Diversity, and Inclusion at Christus Health, an international Catholic, faith-based, not-for-profit health system comprised of almost 350 services and facilities, including more than 60 hospitals and long-term care facilities, 175 clinics and outpatient centers, and dozens of other health ministries and ventures. In this capacity, he leads the integration of diversity and inclusion strategies, cultural competence, and community partnerships to impact population health and achieve health equity. Tiffany Capellas serves as Director of Health Equity and is responsible for establishing and advancing the health equity strategy of Christus Health by working across the organization to ensure initiatives, resources, and tools are effectively leveraged. She leads the implementation of innovative system changes that promote community health, reduce health inequities, and improve patient outcomes. Thank you very much, and Marcos and Tiffany, the floor is now yours.
Thank you so much for that kind introduction. Hello, everyone, and thank you again for joining this webinar. Tiffany and I will cover the questions of why is this issue important? What can we do about it, and how can we integrate diversity and inclusion strategies into the fabric of the organization? And as with every presentation, let's start with a definition. Obviously, the issue of health equity, the issue of combating health disparities is central to all of our organizations as healthcare institutions. Healthy People 2020 defines health disparities as a particular type of health difference that is closely linked with social, economic, and/or environmental disadvantage. These issues of health differences can also be attributed to race, to the patient's ethnicity, religion, socioeconomic factors, can influence health as well, gender, age, mental health, physical disability, sexual orientation or identity, geographic location, and other factors. And when you see at this picture to your left, you see what equality is, which is basically providing everybody with the same care or the same treatment. But, as we've been talking for many, many years around patient-centered care, equity is really what we're after, which is what is it that each individual needs in order for them to experience a healthy life. And that's really what we try to accomplish with this initiative. Obviously, this is extremely complex, as you can see. We look at a study from Kiefer that help us also to understand a little bit about some of these issues and what are the barriers. But before I do that, I want to give you a quote from the Center for Healthcare Governance that says that trustees who understand the cultures, issues, and needs of their patient population can provide deeper insight and make better decisions about how to serve their communities. All right, so let's look at what are some of these issues that present some challenges. In the first square, the study asked a question from leaders, board leaders, and executives in healthcare organizations of what were the barriers that must be addressed to enhance leadership diversity. And here we see differences. It stratified the answers by whether the respondents were white or minority. And 85% of minority respondents agreed that lack of commitment from top management was a barrier versus 53% of white respondents. 72% of minority respondents agreed that lack of commitment by the board was the issue versus 35% of white responders. And then lack of access to diverse candidates was another issue that was also discussed. And really the point is we need to be very intentional if we are to move this needle, the needle in this area. So what can we do about it? Is really the question. We have been in this journey for about 8 years ourselves, and you know, we look at the American Hospital Association Equity of Care Pledge as one of our, and with top leadership support, and we have 4 main strategic pillars that guide our work. Let's look at the Equity of Care Pledge that you see in your screen, and what does it stand for? And it has 4 major areas that it looks at. It looks at increasing diversity in leadership and governance as one of their goals. It looks at a pledge to increase cultural competency training for our frontline staff as well as healthcare providers. Also, making sure that we're increasing the collection and the accuracy of data around our patients' race, ethnicity, language preference, and other socio-demographic factors. And then also improve and strengthen community partnerships. So that is the pledge, and a great way to start is for all of our hospitals and your hospitals to sign this pledge from AHA. Internally at Christus, we said, okay, how do we integrate this issue, this diversity and inclusion strategies? And we look at 4 main areas, or what we call them 4 pillars. The first one is diversity and inclusion. It really is different programs that could help us move the needle in terms of how well do we represent the communities that we serve, or mirror the communities that we serve among our leadership staff as well as governing boards. That's what we look at primarily under diversity and inclusion. Very typical, you know, human resources function. Then cultural competence, which is how do we equip our healthcare providers to really relate at a deeper level and build trust with our patient population, obviously with the goal of improving compliance. The third, and also understanding our communities as well, and what are the health issues and other social issues that affect them. Community partners have how can we extend the safety net from our vulnerable patient populations and extend this care outside of the 4 walls of our hospital by partnering with other organizations within local communities. And then population health strategies is looking at data. We want to make sure that our initiatives are data-driven and not really what's the flavor of the month, if you will. And, you know, we make sure that that data is available at all the local hospitals and local ministries so that they can make informed decisions. So we also have very open, you know, to begin with the diversity and inclusion pillar, we have very open discussions with leadership and governance about diversity composition in all areas. We looked at our frontline staff, and even managers really do represent the communities that we serve and mirror the composition of the diversity there. However, when it comes to board and executives, it's a different story. If you look at this slide that you have in front of you, the little line, the black line with the 3 little folks there, that's the community. When you look at all of our regions within the U.S., that is a demographic composition around race and ethnicity. And then we look at the red bar includes our board diversity. The purple bar is our executive. And you see there that, for example, look at black. We have board composition. We have about 18% black, and the community is about 16% black. So that's like it's a good comparison, a little bit over representation there. When you look at the Hispanic composition, our board's about 18% Hispanic, yet the community is about 38% Hispanic. So there's a gap there that we're actively looking to close. Now, when you look at the American Hospital Association goal for 2020, the national goal set was that board should be at least 20% diverse. And when you put together our board, we're at 45% minority representation, which is a great spot to be However, this, as I said, this has taken years, and it has been a very intentional way of achieving this. However, when you look at our executive leadership, we have good gender diversity, which you can see on your right, in terms of how we're doing. The black number, 45% women, 55% men that are executive leaders. In that regard, we're doing okay. However, when it comes to the racial and ethnic distribution, you see a bigger gap in our African American and Hispanic executives that needs to increase that representation. So in order to continue to move this needle around diversity, we established the leadership diversity goal, which is part of our Compass 2020, which Tiffany will get into that a little bit later. But to further our journey towards a culture of health equity, diversity, and inclusion, we look at improving our leadership awareness of how unconscious bias plays a factor in decision making. So we went ahead and created a threshold level of performance, target, and maximum. Threshold, what we did is, okay, our senior leaders, all the folks, our CEO and the direct report and COO and direct reports, will participate in our unconscious bias training or workshop that will equip them with a common language that promotes inclusive behavior. And this common language was important as we move up and down the organization and talk about these issues. Target performance is that in the United States, 100% of all regions will dedicate a Leadership Development Institute or other leadership workshop for unconscious bias trainings for all managers, directors, as well as regional executives. And this workshop obviously will provide tools for our leaders for managing diverse workforce and increase more inclusive behaviors. And then internationally, in our ministries in Mexico and Chile and Colombia, we look at increased diversity in the leadership when it comes to gender, increase the number of women in executive roles. And then maximum performance is that we actually, that 30% of our new executive hires in this fiscal year will be either African American or Hispanic to help us with that gap that I showed you earlier. And international, that at least 10% of the new hires will be women in executive roles. Going back a little bit with the unconscious bias, these are some of the, this is obviously the book that we utilize, but the goal here was to increase awareness of biases, our own, and the brain in order to manage unconscious bias more effectively. We want to establish a common language throughout the organization, gain insight into our own, do some kind of retrospection, our own unconscious preferences, and the often unintended impact on biases and assumptions. Also learn a brain-based framework to increase self-awareness and the ability to successfully work across cultures and differences. And then provide tools to our leaders for managing diverse workforce and be more inclusive when creating opportunities for teams and projects. And then learn skills and strategies to develop and model inclusive behaviors and create sustained positive behavior change. This has been very open and candid conversations we have had that has helped us to really recognize individually what are our preferences and making sure that those preferences doesn't inhibit us or exclude other individuals. So far, when it comes to the diversity performance, in this year, the goal was 30% of our hires to be minority, they're Hispanic or African American, and that's exactly where we're at. Out of 20 openings that we had system-wide, 6 of the executive hires were minorities, so we're right exactly where we need to be. Internationally, in our ministries, we only had a 10% goal. However, out of 7 openings they had for executive hires, 5 were women, so they're performing at 71%. So that has been quite a success. And again, we have been very intentional about this. So these are some of the ways that we're looking at moving the needle. So to answer the question, what are some must-haves in order to be intentional and integrate the diversity and inclusion strategies into the fiber of your healthcare system? To answer that question, Tiffany will lead us through that discussion.
Thank you, Marcos. I think you hit the nail on the head. The key here is that we really want to be intentional with our strategies. Diversity and inclusion strategies really need a structure has to be a structure that calls the organization to action. It needs to be very intentional and visible for the organization. For example, at Christus, it is one of our destination points to excellence on our company's 3-year strategic plan. These destination points on our compass tie directly to our organizational scorecard. Health equity, diversity, and inclusion is really integral to what we do. All of these metrics are designed to align with these destination points, as well as other top priorities during that fiscal year. This scorecard performance is directly tied to leadership bonus compensation, and therefore it ensures the accountability of the KPIs on it. In addition to our scorecard, there's also a need to have a cross-functional team that is driving the health equity, diversity, and inclusion strategies for the organization. It is the shared responsibility of everyone to ensure that this culture is woven into the organization, not just necessarily the department that holds the title. Our Health Equity, Diversity, and Inclusion Department is chaired by our CEO. This is unique for many organizations. Our CEO felt that it was very important to hold this title because it sets a tone for the entire organization as it being truly a #1 priority. This council does have a top-heavy design, but this is by nature. We have executive leaders from mission, our health plan, human resources, information management, CNOs, COOs, quality and safety. Some of our CEOs of some of our health systems are on it. Communication, our senior counsel, advocacy and government, even supply chain, population health, chief medical officers, and yes, even our CFOs. These decision makers, influencers, and executive leaders from across the enterprise attend these council meetings 2 times a year in person, and the action items coming out of this meeting are championed by our ministries, or rather market leaders for those that aren't in Catholic healthcare that sit on the council. Oftentimes, at these meetings, we review progress of our diversity and inclusion strategies, as well as have guest speakers present on evidence-based practices of interest, and then discuss what that model looks like for our organization and how we're going to implement them. After exceeding our equity of care pledge goals this year for the AHA, we thought it best to begin with the next phase. And this is where we put our data to work and to make meaningful use of it. In alignment with the triple aim, we decided to look at our equity of care and how we were connecting the data to our community. What you see here is an example of our emergency department revisits that were taking place. And I want to make a distinction between revisits and readmits. Readmits are those that are discharged from an inpatient status. Revisits are those that came to the emergency department and then were discharged from that emergency department visit. In this particular facility, we have a 24% revisits of those total ED visits that we had for that year. And we said, why is it that these individuals are revisiting? What are some of the top chronic conditions? What we found is that it was hypertension and a number of other confounding factors that also impact hypertension as well. Then our question was, well, who are these individuals? So we stratified the information by race and ethnicity. We saw that 47% were Black, 1% Asian, 1% Hispanic, 52% were white. So we said, let's look at this white community and what is it that we can do to really kind of drive some of the determinants that are impacting them utilizing the emergency department for managing some of these chronic conditions. But before we did that, we said, let's look at our community profile. Does it also represent what we're seeing here with these specific chronic conditions? What we saw is that it really was the Black community that we should focus on, because the Black community only consisted of 32% of that community. So there was a disparity and overutilization among the Black community that we really needed to hone in on. with that information, that 47%, we said, okay, well, what's driving? What are the driving factors? Could it be insurance? Let's start there. Turns out, no, it was not insurance. 95% of them had insurance. Could it be that they didn't have a PCP? Nope, it wasn't that either, because 81% did. What about gender? Well, we saw that majority were female, which aligns very much with national statistics. We saw that 67% were over age 55. We also looked at religion. As we think about partnering with our religious communities, even though this is Catholic healthcare, if we need to partner with the Baptist community, then let's do so. Let's meet these individuals where they're at and provide them with the resources that they need. We also looked at geographic location. Where is it that these individuals live? What part of the community? What zip codes? So we use that information to then inform our community interventions and the community organizations that we needed to partner with. This year, our goal is a little bit different. So we've moved on to really looking at how we can identify these individuals sooner, before they revisit. And here we're looking at catching them when they come into the emergency department and identifying them in the ED, and then having a case manager, someone from a care manager, community health worker to then do an intervention with them. This is in alignment, as I mentioned, with our triple aim and the Equity of Care Pledge from the American Hospital Association. We've been focusing on this, and it is really helping us to improve our internal clinical processes in identifying these patients visiting the emergency department, really for primary care reasons, which is what we don't, if they need to be in the emergency department, let's take care of them. But if they're utilizing it for primary care, it's not the best care for them. So we are looking to identify, do they have a PCP? Do they have a need for medication assistance? Do they have a need for transportation assistance? Or simply, do they need to better understand their condition? So these are the 4 issues that we're looking at. Granted, there are there's a slew of other social determinants of health that could be impacting them, but we had to start somewhere. So we started with those 4. We started small. So this particular population that we're looking at is hypertensive, those who are utilizing it for utilizing the emergency department primarily for their hypertensive care. And we're only looking at 25%. We set a very low threshold, 25%. Can we reach 25% of these patients that are coming in? Our target was then raised to 35%. If we can get 35% of those patients and connecting them to the community, that would be great. So there's a lot of behind-the-scenes work that needs to take place, such as modifying our electronic medical records, modifying our population health platforms, and changing clinical processes, even the way that our clinicians think and operate. These things take time. And so setting low thresholds really makes it achievable as we work on some of those back-end challenges. Lastly, our stretch goal for this year looks at putting a plan together, working at how we can connect with our community-based organizations or our primary care providers that are helping these patients. Our focus was an entire population, but we do have a kind of a microscope on our vulnerable communities as well, such as our minority and our uninsured. And we want to know, are they showing up for those doctor's appointments that we are referring them to a PCP? Are they getting the medication assistance that they need? Are they getting the transportation assistance that they need? We want to be able to report health outcomes. So if we can connect to those community-based organizations, we'll know how the patient ultimately is doing. Here's a snapshot of our scorecard right now. We're looking at, yes, did we connect them? We're also looking at a number of other measures, such as how many of them are revisiting, how many referrals have been made. Again, we're focusing on our PCPs, medication assistance, transportation assistance, and education for right now. So this is what we're doing around equity of care. Another strategy that we're utilizing for integrating diversity and inclusion strategies into the fabric of our organization is the creation of our Diversity Leadership Award. This award is something new for us this year. We're looking to recognize leaders, either formal or informal, who go above and beyond the culture, go above and beyond to create this culture of health equity, diversity, and inclusion. We look at, are they adding value above and beyond their role as in whatever role that they serve? Are they working with other departments within their health system? Or are they working with other organizations outside of the health system? So what partnerships are they forming? Is it innovative? What kind of impact are they having? Is it something that's replicable and sustainable? Can we share that with our other health systems so that it then can create a ripple effect throughout our organization? And lastly, and most importantly, does it align with our core values as an organization? Dignity, integrity, compassion, service, and excellence. We then have, each of our ministries will have select either an individual or a team that they want to recognize, and then as an enterprise, our CEO and our Health Equity, Diversity, and Inclusion Council will select who will be the top candidate that is then recognized before our governance board. In addition to an internal award, it's also important to share your industry successes with associates as well, so that they know that as an organization, they are working for and supporting an organization that's highly recognized among its peers. Here are a few awards that our team has won over the past few years. We have the Equity of Care Award from the American Hospital Association that we've been awarded and recognized for, the Excellence Award for Healthcare Diversity from the Texas Diversity Council, as well as the National Diversity Council Award. This continuous reinforcement is what our associates need. Awards are really only one way, but we also leverage education and keep it at the forefront of our associates' minds. Annually, we release an online module or two that will drive that focus for the year. We cycle through many different courses. Shown here are our last year's or current year's modules. We've got the two cultural competency and inclusion courses that we released last year, one that was released to all of our associates, and the other that was released to our clinicians to really focus on providing that culturally competent care at the bedside. And then this year, we released a new language access services course. This course is really taking center stage, this program, this strategy that we've recently had a focus on. There's been some changes at the federal level around how we provide language assistance to our limited English proficient and deaf of hard of hearing patients, and this is in Section 1557 of the Affordable Care Act. And so it made us take a closer look at our own offerings and realize that we needed to put more structure around this and create an enterprise-wide program for all of our regions. Our patients really shouldn't be getting different quality or have different access to resources based on the facilities they visit, and we saw that in some facilities they only had access to one particular service and maybe not others. So we really wanted to standardize that across our organization. First, we looked at policies and procedures and put some policies in place, making sure that the policies were the same across the organization. We looked at, are we collecting race, ethnicity, and data collection upon registration? How is it that we are meeting the needs of our community, and what does our community look like? We looked at the delivery system. What are the different modalities that are offered, whether it's telephonic interpretation, video, remote, use of bilingual staff, and qualifying and training them so that they are proficient in being able to provide interpreting services. Looking at our use of contracted professional interpreters and making sure that those were available in all of our markets. And then also translation, the written form of interpreting We needed to make sure that all of our documents that needed to be translated were translated and accessible to our associates. We didn't have multiple versions of different translations out there. So putting some structure and standards around that. Looking at the proficiency of our bilingual staff and training them, training our associates on these services that were made available. And then lastly, monitoring and evaluations. We look at patient satisfaction scores. We're looking at our physician engagement scores and how they feel about these resources that are being made available. And then tracking utilization, making sure that we are truly meeting the needs of those patients who are identifying as preferring to speak with a provider in a language other than English. Now, granted, Christus has been on this journey for a while. It's actually taken us 8 years to get to this point. However, as you consider starting this journey or continuing this journey, I would encourage you to sign up for the Equity of Care Pledge from AHA. Another thing that you can do is have your board or leaders take the implicit bias test. This is a test that was developed by a Harvard professor and a University of Virginia professor. It provides a window into how we have been socialized and the potential areas of unconscious bias. It also highlights the areas where we can begin to work on being aware of our own biases, where they show up, and then when we need to put them in check. Another resource I'd like to leave with you is the Brain States Awareness Profile that Marco spoke of earlier. This has helped our organization. The authors of the Neuroscience of Inclusion, they created this profile to help our leaders to receive behavioral feedback in 3 key performance areas: inclusion skills, creating trust-based communications, and decision-making. We also wanted our leaders to be able to recognize their brain state tendencies and underlying thinking or feeling patterns, override those unconscious biases more consistently. They're going to have them. We all have them. But what are they doing to override them on a regular basis? And then be able to shift brain states and access higher levels of thinking and problem solving. Remember, this is a journey. But it does need to be an intentional one. With all the competing priorities in healthcare, it is very easy to see something so important fall by the wayside if it's not placed front and center for everyone to share accountability. I want to thank you for your time, and I want to thank the Texas Healthcare Trustees. Please feel free to contact us here at Christus, either myself or Marcos. We have provided as well some references for you as well, as we referenced throughout the presentation, and feel free to peruse them at your leisure. Thank you.